Slit lamp starts here with a source of light. Light comes through a filter, then it reaches some lenses to be reflected into the patient's eye. The observer uses a binocular microscope to see a magnified image of the patient's eye. So we have the lamp here. We can get light through this path. We can put some filters, mirror here to the patient's eye, and the microscope to see a magnified image of the patient's eye. The phenomena of slit lamp depends on light scatter. In order to see anything, light should fall on a surface and comes back to the eye to be observed. So you need to stay in a dark room. This will increase the contrast so you can see more details, and also this will increase the sensitivity of the retina so you can observe more and more things. We should avoid having a room fan because rapid air currents will cause evaporation of the tears, and this will cause the patient to be irritant. Examination of the anterior segment. We start by using a diffuse illumination. We widen the slit. We have a diffused light to the whole surface of the eye, so we get an impression of all the structures, whether they are normal or abnormal. For example, here you can notice that there is a ring here. This is an edge of a contact lens, and there is some deposits on this contact lens. On this side you can see here that the pupil and the iris not seen visibly well, so you get a hazy cornea. So always start with low magnification. Then you start to make a narrow slit. So you use shutter to get a very narrow beam to focus on an area of the whole surface. As you notice here that the microscope focus and the source of light, they come to the same point, so we have a direct focal illumination. We can use a widened beam like this or a very narrow beam. A widened beam, here you can see this is the anterior surface and this is the section, so at this points they are located at the back surface of the cornea, but these points you cannot tell whether they are on the back or inside the cornea itself. Now if you narrow the beam to a very narrow slit, you are going to see this appearance. The anterior surface of the cornea is formed with two bright lines and in between a dark zone. The first bright line is the interface between the tears and the epithelium, and the second bright light is the Bowman's membrane. The epithelium itself is seen as a dark zone. We don't see the epithelium. So the first bright light is between the epithelium and the tears, and the second bright light is the Bowman's membrane. Then comes the stroma, and lastly we have the distal endothelium membrane. Here you can see a section in the cornea. In order to see the first two bright lines, you need to get a very good illumination to narrow the beam to the maximum and to get a high sensitivity of the retina and give a good focus of the slit lamp. What do you see here? We can see that the cornea is hazy, and in this section we notice that the central part of the cornea is not thin. It should be thinner than the periphery. So this means that we get edema of the cornea. We see a reflection here. The edema starts from the back surface through the stroma, and fluids accumulates here under the stroma, under the epithelium. So we get one bully here of the epithelium. So hazy cornea can be due to edema or can due to scar tissue. Edema, we notice that the cornea is thickened, while scar tissue, the cornea is of a normal thickness or thinner than normal. Normally we can compare between the central and the periphery, or we can compare between both eyes to comment on the thickness of the cornea. Here you can see we get an oval pupil, we get an iridectomy here. The cornea is not that clear, but in a section you can see that the central part is thinner than the periphery. Here, marked haziness, we don't see through the cornea, and on a slit section you can see that the central area is markedly thick, so it's a corneal edema. You notice here that the back surface of the cornea, you get these folds of the distal membrane. Folds of the distal membrane occurs because when the cornea gets thick because of edema, the posterior surface moves backwards into the anterior chamber. So instead of being stretched on one level when it's in a little bit, it becomes stretched in a shorter surface, so you get these folds. Later, when the edema subsides, the cornea returns to its normal thickness, and these folds will disappear as the back surface will go back to its normal position. Here you notice that the pupil is dilated, and in this section of the cornea we notice that this part is thickened, so we get a localized edema in this area of the cornea. Here in this section we notice that in this area the cornea is thin. It's almost 40% of the normal thickness, so we get thinning of the tissues in this area. Here we see that we get some opacity here, we get vascularization into the cornea. These vessels are superficial vessels because we can follow them to the sclera, and also because they are branching vessels. In case of deep vascularization, they should stop here. We cannot follow them outside the cornea, and inside the middle of the stroma, tissues are compact, so they don't have a chance to branch or to run wavy. They run just straight, but here the superficial vessels run wavy and they are branching. We notice here that this opacity and the central is less opaque, and in a section you can see that the central area is thin, so we get thinning of this part of the cornea and opacity of this part. Here we can see that there is haziness in this area of the cornea. Now here, this is an old scar in the cornea. It's a V-shaped. In different pictures we can make different sections, and notice that the extent of the opacity, here opacity is in the superficial 1/3. If we move to another area, you can see that the opacity starts in the anterior surface, getting very deep to reach toward the posterior surface. Another section of the opacity, you notice it is in the middle of the stroma. Another part of the lesion again in the middle of the stroma. So simply by making sections in different parts of the opacity, you can tell which part of the opacity is superficial and which part is deep, and you can tell if this a penetrating or just a lamellar opacity. As you notice here, this is the section in the cornea, and you can see there is an opacity. It extends from the anterior surface of the cornea reaching to the back surface of the cornea. So it was a penetrating trauma, led to a penetrating or a total opacity which runs in a valvular or an oblique fashion. This is a case of a keratoplasty. You can see the graft and you can see the sutures. Notice the cornea here, the central part is thick compared to the periphery, and there are folds in the distal membrane, and you can see here the light on the iris, and there is no anterior chamber. The iris is on the back of the anterior chamber. Here we can see a section in the cornea, and there is opacity, some material here, and this material, as you notice, are on the back of the cornea. So this is a lens which has been opened, and you get this material in the anterior chamber. You cannot judge this part of the white area whether it is in the cornea or not, or in the anterior chamber. But here you can tell that this white material is in the anterior chamber. Again, we notice the depth of the AC here between the iris and cornea, and here between the iris and the cornea. So the lower half of the AC is very shallow compared to the upper half. Here there is some pictures of a cystic lesion of the iris, and we want to notice the relation between the cyst and the back of the cornea, and we make different sections. Here we get some contact between the cyst and the back of the cornea, another area more contact. This is very important because if you want to get into the anterior chamber with some instrument to separate or to deal with this cyst, you have to start with an area where there is no cyst. So you have to make different sections over the cyst to know the relation between the anterior surface of the cyst and the back surface of the cornea.